you ate a lot of food. I heard some folks stay here over break. Didn't go home. So, if you are going to be staying over Christmas break, be sure and let Dr. Hawkins know, the BSN department chairperson. So, we're trying to keep tabs of who's staying over breaks and stuff because we want to have everybody feel hospitality here in Louisville. So, we want to make sure everybody's got somewhere to go. All right. Okay. Well, if there's nothing else, we're going to get started.
So no class next Friday?
All right. Remember how I talked about my bias? And so my bias is labor and delivery. So I would say the area that I'm the weakest in is probably newborn. Okay. So I do tend to talk about newborn superficially. The other thing is newborn overlaps a lot with pediatrics. And so it'll be really important. Sorry. A group text has just now started, so I need to make this quick. It'll be really important that you focus in on basics. So when we talk about sick babies, a lot of times our answer is they go to NICU, okay? The care of the baby in NICU will be discussed more in pediatrics than it will be in this course. When we talk about sick babies, the big things that we focus on are temperature, hypoglycemia, poor feeding, and jaundice. Those are really about the extent of the sickness. So when we get into heart defects and things like that, that's gonna be covered in much more detail in pediatrics. So in the chapters where it talks about newborn at risk, there's 2 chapters. That PowerPoint will be very short. I think, again, the PowerPoint will guide you through what you need to focus on. There's a case study on Evolve. I do not recommend the newborn at risk case study. Again, it goes too advanced into pediatrics for us. Okay. All right, so again, some of this will be review, and we'll go through this fairly quickly, hopefully get it done before the break. All right, so one of the first things that babies need to do is take a nice big breath. And so we really want to see that first breath be a good one. We want to hear crying, and that initiates a big change in the baby. From that breath, that will contribute to the change from fetal circulation to neonatal circulation. So you would think, oh, the baby just takes a big breath and everything's good. Well, all of these things, what stimulates that first breath? Remember, when the baby's in utero, the baby's lungs are essentially full of fluid. And so as the baby is being delivered, what happens, again, the chest is kind of compressed, and as you come into atmospheric air, there's this chest recoil that brings in air, and so there was fluid there. The air pushes the fluid out, the baby cries, and hopefully, again, the baby's getting rid of that fluid. But with each cry, each breath, we're getting rid of fluid in the alveoli. And so that happens due to various things: the temperature change, the light change. You've been in a dark, wet, very warm environment. It's cold, it's dry. Somebody's rubbing your back, flicking your feet, putting a bulb syringe in your nose, and all those things. When you move around, you breathe deeper, and the same thing happens with babies, okay? Now, as this air goes in, it's not a light switch, so it's not like whew, everything's set and ready to go. It takes some transition. And so that's one of the reasons why, as a nurse, I'm doing APGARs at 1 minute and 5 minutes for most of our babies. If it's not above 8 at 5 minutes, then I'm doing another one at 10 minutes. But I need to give the baby some transition time. So again, the first thing I do when I resuscitate a baby, I stimulate the baby, I dry the baby off, I will do bulb syringe if I need to clear the airway of secretions. But I want to see a baby that's pink, moving around, crying, good tone, making noise, moving around. Those are all very good things. So this kind of shows you as the baby's taking a breath in. So remember, if this is clear amniotic fluid, we get rid of that very easily. If it's meconium stage fluid, it's thicker and it causes more problems. If I don't have a good labor process, because we think in labor, what happens is some of that fluid in the alveoli decreases. If I'm a scheduled C-section, well, I had no labor, So there's kind of more of this residual fluid left in, and that's why, again, babies with C-sections a lot of times have more difficulty in getting rid of those secretions. Now, when you think about why do babies have difficulty with respiratory function, some of it has to do with their maturity level. So we want them to get past at least 37 weeks or so to be term because of the surfactant. The surfactant is needed to help keep the alveoli open. The alveoli is where gas exchange occurs. Now remember, the babies are not breathing air in utero. They breathe air and the outside air. Now, if I'm preterm and mom got steroids while she was being treated for preterm labor, that's going to jumpstart my surfactant production so that hopefully my alveoli will stay open once I'm delivered. As the baby starts transitioning, and again, is breathing rapidly, 30 to 60 breaths a minute, and I would say brand new babies tend to be on the fast side of that, okay? So if I'm moving around and I'm crying, it's just like you if you're running. If you're running, you're breathing harder and faster. Well, the baby's responding to a stressor, so they tend to breathe kind of harder and faster. But they should kind of calm down. We don't want them at rest, sleeping, breathing 80 times a minute, okay? But the very first kind of, you come out into the world, you have all of these changes that have happened. We often see that first respiration count kind of high. As the baby starts breathing in with each gasp of air, that fluid is any residual fluid will pass into the vascular system. But this is the reason why if you were to listen to a brand new baby's lung sounds, you might hear some faint crackles. So that's another thing that I would suggest you look at, what would be normal at 1 hour of birth versus what would be normal at 1 day of birth versus what would be normal at 3 days of life, okay? So for example, a baby with crackles in the first hour of life would not really concern me that much. But if the baby had crackles at 1 day of life or 3 days of life, well, that's different. Does that make sense? And we'll talk about mom in the same manner because there's a lot of changes that occur. So for example, we'll talk about jaundice. Jaundice at 3 days of life would not really concern me too much. That's a pretty common phenomenon. But if you have jaundice at 1 hour of life, that's completely different. Periodic breathing, do you remember what that is? You have apnea for how many seconds? Normal, this is normal.
A few seconds.
Close. We're having periodic breathing right now. It's 20 seconds. That was 20 seconds. Seems like a long time, doesn't it? 20 seconds. So what happens is that babies take breaths, and then they take breaths again, okay? So as long as it's less than 20 seconds, that's periodic breathing. If it's longer than 20 seconds, I get into apnea. Apnea is bad. Any apnea, because when babies have apnea, they may or may not have a change in their heart rate, but we need to investigate why they're having apnea. And we don't want to see signs of respiratory distress. So remember that babies tend to breathe through their nose. So we might see things like rapid respiratory rate, nasal flaring, grunting. Shouldn't be making that noise when they're breathing. Sometimes we'll see intercostal retractions. Okay, those would be signs of respiratory distress. Is there any other signs of respiratory distress? Has anybody had a baby in respiratory distress? Okay. Is there anything else that you can think of that stuck out in your head about that baby?
Well, her oxygen was really, really low, but I just remember her grunting. It was like she was trying to get a breath and she
Right.
They just kept suctioning her with the bulb that wasn't working.
Mm-hmm.
So then they put the endotracheal
Mhm.
tube down there and kept suctioning all that out. She
Another
was
one,
gurgly,
she had a lot of secretions
A lot.
because she came so fast and she had meconium.
Mhm.
Was she early?
She was, yeah. No, she was late. She was 41.
Okay.
Yeah.
Another one is seesaw respirations. So when babies breathe, their whole chest should move together. You shouldn't see the abdomen and the chest out of sequence. That would be abnormal.
Is that like a flare chest?
Kind of. think of seesaw, I just think of seesaws out of sequence. Flail chest can get you into like diaphragmatic hernia and some other stuff, so. Okay. All right, so remember we did fetal circulation many weeks ago, and we talked about some structures that were in place during fetal circulation. So things like ductus venosus, foramen ovale, ductus arteriosus, okay? And we talked about how in the fetus, we have high pulmonary circulation or low pulmonary circulation. I'm sorry, pressure. High pulmonary pressure or low pulmonary pressure in the fetus. Yep, high, it's restricted, because the lungs don't have to do a whole lot, okay? Now, what should happen as you go from fetal into neonatal circulation is the inverse, okay? So I had high pressure, high pulmonary pressure in the fetus. I'm gonna have low pulmonary pressure in the neonate. And the reason why is now the lungs have to do their job. And so there's a shift. And so what happens is that I have low pulmonary pressure, and again, there's an inverse relationship, so systemic pressure will start to come up. The other thing I would say, you want to be very careful. I'm very sloppy with my language. I'll say neonate, I'll say newborn, I'll say baby, and I'll say infant, and they all mean the same thing to me, okay? So I'm not trying to be tricky by saying, oh, this is neonate, but this is newborn, or that. So those are all, I'm talking all about the same time frame here for this baby. So in the fetus, the lungs aren't doing that much. And so as I move into, I take that first breath of air, I have more oxygen coming in. And so Lori mentioned that her baby's oxygen saturation was very low. Remember that it takes some transition. It could take 7, 8, 9 minutes before we see pulse ox get up into what we would consider normal, like 90% higher. And it has to do with the oxygen that's circulating through the baby's blood. And as I take more breaths of air in, and I have gas exchange occurring, and I'm responsible for my own circulation, but structures change. So not only does the pressure change, but structures that had been patent or open will now close. And so the foramen ovale, which had been from the right atria to the left atrium, will now close. There's more force on the left side of the heart than the right side of the heart, and so that will shut closed. What closes the ductus arteriosus has to do with the more oxygen that's present in the blood. It also has to do with a change in the prostaglandins that are present in the baby. But the ductus arteriosus, that tends to be one of the later things that closes or changes. And so some babies will have what's called a patent ductus arteriosus, or a PDA. Sometimes it can take, 4 or 8 hours or so to close. And some babies it doesn't close right away, but that's one of the reasons why we sometimes have murmurs in newborns, and we're not that alarmed by it. It's actually just caused by maybe one of those structures has not quite closed all the way, or maybe things have not quite shunted and things are not in sync quite yet. As long as the baby's stable, color's good, moving around, we don't see any problems with that. In our neck of the woods, a lot of times they will go ahead and do an echo on a baby that has a murmur, just to try and make sure there's not any type of congenital heart defect. The other thing is, for us, we do a lot of screenings for congenital heart defects. So that may include looking at things like blood pressure or doing a pulse ox on the baby, but those are often done after the first day of life to give time for this transition to occur. Okay. Are you seeing that in clinical? Screening for congenital heart defects? No.
We did it.
Okay. So that's your homework for tomorrow in clinical, is to talk with your clinical instructor about, do we do any screenings for congenital heart defects on newborns? Okay, and we'll talk about and follow up on that on Thursday. So I mentioned the foramen ovale, I mentioned ductus arteriosus. I didn't really talk too much about ductus venosus. It bypassed the liver, okay? And so it caused a lot of circulation to bypass the liver. It's an important structure, but again, it's not anything that I'm gonna listen to or anything, but remember, we're gonna get circulation to the liver now that the baby's on their own. The placenta doesn't do the job of filtering things through the liver. but that will come into play when we talk about the immaturity of the liver and how the liver function needs to catch up a little bit when we talk about jaundice. So in terms of the heart, we want the heart rate to be the same as we did in the fetus, 110 to 160. The baby might have a little bit of bradycardia during sleep. So if they're in that really deep sleep mode, their heart rate might be lower. And again, as long as it's regular, we have S1, S2, we're not too alarmed by that. As long as it comes up when the baby's active and moving around, that's good. I would not recommend to a student to try and assess heart rate and respirations with a screaming baby. They're very loud, it's really hard to hear. So sometimes in that deep sleep, it's really easy to be able to count. When you count heart rate on a baby, I would not, count 107, 108, 109, because you're gonna miss about 5 beats. So it needs to be kind of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 20, and so on. It's very fast. You will see a lot of people who will only count for like 15 seconds and multiply times 4, 30 seconds and multiply times 2. It's kind of shorthand. I will say sometimes for the rate, that shorthand is okay, but you do want to listen for a full minute because you may not be able to detect any abnormalities there unless you listen for a full minute. For peripheral pulses, I always, it makes me smile when students tell me, do I need to check pedal pulses in my baby? It's like, no, they're really teeny tiny and it's really hard. They got those stupid little feet. So primarily when we're talking about peripheral pulses in babies, we're talking about femoral pulses and brachial pulses. Okay? So if you needed to do CPR on a baby, you need to check pulse on a baby, you need to teach mom how to check pulse on a baby. They should not be going in that little short chubby neck because we're not going to find anything. They need to know. And that's another thing that I think it's good for students to do is to palpate, because you can see how very easy it is to obliterate that brachial pulse on a newborn. The other thing is newborns are not very cooperative. So when you try and hold their arm out, they resist you quite a bit, so it's a little bit challenging. Okay. With blood pressure at birth, I think Professor Broderick took it off your form. I don't know. It's been on the newborn form for a while, and I don't really know too many people who do blood pressures at birth as long as it's a healthy baby. Most facilities wait and delay that, but if they're concerned about the baby, if the baby's unstable, they'll use that little teeny tiny white, it's so cute, it's like 2 inches, and check the blood pressure on the baby. Notice with babies, they're gonna have much lower blood pressure, okay? We would not call that hypotensive, that's very normal for a baby. A new baby has a very short pipeline, has very little blood, and there's no plaque, there's no vasoconstriction there. It's smooth highway. It is brand new, easy flying. You can take your convertible, super easy drive, and that's what you see in blood pressure. Okay.
My nurse on me, these babies were born like in the middle of the night, and then I'd come, she actually took the cup and she said they always take the blood pressure in the arm and the leg on the same side to make sure that they were correct, that they were the same.
That's your screening for congenital heart defects.
Oh, was it?
Yes,
Okay.
yes,
So there you go.
because if there's a difference, that can indicate there's a coarctation of the aorta, a constriction there, or that there is a patent ductus arteriosus.
Okay.
Yep. Which is what that says. There you go.
I didn't even see that, I'm sorry.
That's all right.
I'm gonna wait
That's
till
all
you
right.
talk.
But again, when we think about vitals on the baby, for me, it's temp, pulse, and respirations. And when I say pulse, I mean apical. So if I were a nurse and I would want to report to the doctor, I would do usually an axillary temp, apical pulse, and then respirations. All right, so let's talk a little bit about the hematologic system. For us, most of our babies get cord blood obtained at the time of delivery. And then from that, there's information such as what the blood type the baby is, what the RH factor is, so that way we know whether or not mom needs RhoGAM. The other thing that you will see done a lot is cord gases, okay? So with cord gases, they have a little section of cord, they inject the syringe, they send it off right away. That is to give us real precise information about the baby's oxygenation status at the time of delivery. So it's almost like arterial blood gases on the baby, but it's kind of that in utero. So it kind of gives us an idea of how hypoxic was the baby at the time of delivery. And remember, babies are hypoxic. So if you're looking at those cord gases, the values don't really jive with what you would consider normal ABGs. They have different norms. But again, it's just a picture, it's just a data point for us to consider. So if your baby had a lot of D cells and your cord gases reflect that, it says, oh gosh, it's a good thing we did that stat C-section because the baby was pretty hypoxic. versus some people get cord gases and their baby had ABCARs of 9 and 9. And you're like, why did they do cord gases? Just what we do at our hospital. Okay. Now, some other things that we can get include from the hematologic system. We can look at their white blood cell count, their hemoglobin, hematocrit, and their platelets. Now, for babies, their hemoglobin and hematocrit, notice it is higher than what you would consider kind of normal in the adult. Not by much, just a little bit, okay? So hemoglobin 14 to 20, hematocrit 43 to 63. With babies and their blood volume, one of the big changes in clinical practice that has occurred is delayed cord clamping. And so this actually came from the World Health Organization, there we go. And the idea is that we want to delay cord clamping at least 30 seconds or more if we can. In the past, there was this concern that if I delayed cord clamping, I couldn't resuscitate the baby. I might fluid overload the baby because when the baby's still connected to the placenta, there's still blood kind of pulsing through to the baby. Well, they've actually done research and found that that's actually a really good thing, and that's one of the best things you can do is to make sure that baby gets that final kind of last gasp from mom and not cut the cord right away. So as a nurse, if you had a patient who was delivering precipitously, there is no rush to cut the cord. You can leave mom and baby attached. The placenta can deliver on its own in 15, 30 minutes. It's not gonna hurt anything. Eventually the cord stops pulsating, but ideally we wanna let that cord continue to pulsate and we delay cutting the cord so the baby gets that last little bit of volume. Now with that volume, what that does is it will help prevent complications later on down the road like anemia. Red blood cells in the newborn, they're a little bit different than red blood cells in us. They die off a little bit sooner. And so what happens is that baby kind of has this high-ish hemoglobin hematocrit at birth. The red blood cells are dying off, but I'm not quite making new ones yet, so I drop a little bit, and then as I get a few months older, it kind of comes back. And so they have a little bit of that physiologic anemia, very similar to what mom experienced, but in most babies, you never pick up on it. Baby tolerate, we don't do anything about it, but that is one of the reasons why, for example, formula, infant formula, is fortified with iron, is to help kind of deal with that little physiologic anemia that babies experience. When you look at the results of your blood test, one of the things to ask yourself is where did they get the test? Did they get it from cord blood? Did they get it from a heel stick? Heel stick is capillary blood, and so sometimes the red blood cells have been ruptured with the specimen. Sometimes it's hemolyzed, so you don't really get a good result there. So those things can all impact your result. The other thing is gestational age. So again, when I'm talking about this, I'm talking about term babies, not talking about preterm babies. There's different rules with preterm babies. With newborns, similar to moms, remember mom's white blood cells increase in labor. They say increase during the postpartum period. Newborns are also that too. The problem with that though is newborns still, their immune system is not mature enough to fight infection. So even though they have these high amount of white blood cells, they can't fight infection very well. So let's talk about coagulation. In terms of coagulation factors, okay, the key thing with this is that you need vitamin K to synthesize those coagulation factors. Well, the gut is sterile, okay, so there's not kind of the normal flora in the gut to be able to absorb vitamin K from your nutrition. So we jumpstart that when we give you an injection of vitamin K. So it's a normal physiologic process that we're just kind of helping kind of speed up a little bit. And one of our reasons we do this is because if you don't have coagulation, you might have microscopic hemorrhages. Now microscopic hemorrhages like in the eye and things like that, they might seem kind of minor, but if you had a brain bleed or you had some type of trauma with delivery, then that could be significant. Think about things like a cephalhematoma, things like that. So again, vitamin K is given prophylactically, and the idea is to prevent this hemorrhagic disease of the newborn. They are finding there are more and more parents who are refusing vitamin K, and then that results in babies having complications, and those babies then are being seen in NICU and pediatric wards. Because you can't always, the baby isn't always able to give you visible symptoms of hemorrhage. And so you'll pick up on subtle things like a change in behavior, lethargy, they won't eat, It's again, kind of insidious, so.
Is there a reason why they don't want the vitamin K?
A lot of it is belief, personal belief. They don't want medications given to the baby. They feel like it's not needed. It's kind of like Pitocin. I think a lot of people are like, oh, I don't want any Pitocin, I'll just nurse the baby. So again, vitamin K jump starts the coagulation process. The administration of vitamin K has nothing to do with bilirubin. Okay? It's a different process that we're talking about when we get to bilirubin. When I think of bilirubin, I think of jaundice and I think of the liver. All right, this is another thing that I sometimes I'm fussy about, is temperature regulation. And I think it's because students have come from a med-surg adult and they're very focused on heart rate and respirations. But for me, as a nurse on mother-baby, temperature has every bit as much weight. So remember, in adult land, it's like, oh, don't worry about taking the temperature. Babies, it's the opposite. So anytime you're uncertain about a baby's status, if I want to check the baby's vital signs, I'm going to include temperature. Temperature, pulse, and respirations at a minimum. So with babies, they have less sub-Q fat. They have very thin skin. You can see those vessels compared to adult skin. So they lose heat very rapidly. They have a large body surface area that is different than BMI, okay? They don't have a large BMI, they have a small BMI, but they have a large body surface area in relation to mass. You think about babies, they're in the position to conserve heat, okay? Well, if I'm preterm, I'm not flexed, I'm extended. I have even less sub-Q tissue, I'm gonna lose even more heat. With term babies after 39 weeks or so, they have this brown fat. And so what happens with this brown fat, it actually can be metabolized to generate heat, thermogenesis, so it generates heat. So a late preterm baby, like a 36, 37 weeker, would not have that. So again, having more problems with temperature regulation. If you have a low birth weight baby, so let's say you had a baby who was IUGR or SGA, maybe you had a baby who was post-dates, but mom was measuring size smaller than dates, I would be concerned that that baby would be at risk for thermoregulation. Okay? And so some of you may be taking temperatures with Fahrenheit, some of you may be using Celsius. In my experience, the warmers tend to use Celsius. Are you noticing that at all? Some have both, Fahrenheit, Celsius, which is nice. Anybody had a baby in a warmer or seen a warmer in nursery? Do you recall what it was set at? So you might want to check tomorrow when you're in clinical. It's funny, different folks will set things at different, and they you'll see some nurses, they make adjustment off the size of the baby. But in my experience, it's kind of like 36.8 in that range Celsius. Some people do 37 Celsius. And the whole idea with the warmer is if you put the baby under the warmer, it's radiant heat. You don't want to clothe the baby. You want a diaper because you don't want the baby getting mess everywhere. And you have a sensor that's attached to the baby so the warmer knows how to radiate. If I just put the baby under the warmer with no sensor, the baby can actually get overheated, okay? And so if you have your baby in an isolette, does everybody know what an isolette is? It's kind of the little plastic shielded, baby cart is what I call it. But again, it has a setting on it, and so again, it keeps the ambient air around the baby at a set temperature so we don't have loss of temperature. In some situations, they'll do things to help conserve heat for the baby. So for example, with a preterm baby, you might see them use plastic wrap and put plastic wrap to help minimize heat loss that can occur from the baby. But that's one of the things that we found through kangaroo care is mom is actually one of the best warmers. It helps the baby stabilize much faster if we just put the baby up on mom's chest. It facilitates bonding and breastfeeding, and baby's temperatures are more stable, rather than whisking them over to the warmer and having strange people do all kinds of funky things to their baby. And again, they actually lose heat, making all that stress underneath the radiant warmer. But that's often what happens in C-sections, is you're whisking that baby over to a warmer because mom's on the OR table. So that's why with C-section babies, we're concerned about airway. We're also concerned about temperature. So our friends, the 4 methods of heat loss: radiation, convection, conduction, and evaporation. Ring a bell? So babies, if they're losing heat from their bath, what method of heat loss? You have liquid on their skin that air is blowing across, so it's evaporation, okay? If I put a stethoscope on the baby that's cold, it is directly touching the baby. Conduction's touching. Convection is air. So if I put my baby under the air conditioning vent, that would be heat loss through convection. When I think of convection, you know, we just had Thanksgiving convection ovens. They use air to keep the temperature constant. And then when I think of radiation, I think of either radiant warmers, so that you have heat waves that need to get to the baby's skin, or exposure. So in other words, if I keep the hat off and the baby uncovered, they're gonna have heat loss through radiation. They're not touching anything that's cold, they don't have any air currents, but it's just from their skin temperature loses to the air, because the ambient air is lower, and so that heat gets dissipated in the air around them. I want you to feel really good about this, because I can fully anticipate there will be an example of different types of heat loss, because we do a lot of teaching about this. We need to recognize it as a nurse, so when you go in and see, everybody wants to show off their baby, which I totally encourage, but you need to do it very quickly. And showing off a new baby at 1 hour of life is a little bit more than a baby at 3 days of life. A baby 3 days of life can manage his or her temperature much better than the baby at 1 hour of life. Okay? Do we need to talk about this anymore, or you feel pretty good about it? So tomorrow we're going to ask about screening for congenital heart defects, and then I want to see about warmers and what we set the warmers at in terms of degrees Celsius. All right, the liver. With the liver, the baby's liver does give us some iron storage. And this is, again, a healthy baby who had good nutrition when mom was pregnant. Usually the baby has enough energy to deal with physiologic stressors. And so birth is a stressor. Now, we need to establish every breathing circulation, but we then ideally need the baby, if they can, eat. And that's one of the reasons why, if we can, we want to get them to the breast, okay? Now, if you've got a baby who is hypothermic, temperature's low, they're conserving a lot, they're expending a lot of energy trying to bring their temperature up. It actually causes their glucose to get lower and lower and lower. So hypoglycemia is certainly a problem. And if you're hypoglycemic, you actually will have later problems with jaundice as well. Now, in this situation with hypoglycemia, the slide says 40. I know there are some sites that use a criteria of 45. So I would never ask you anything between 40 and 45, okay? But I would hope that you would know if your baby's glucose was 37, that's concerning. I need to do something about it. If the baby's blood sugar is 52, I'm okay with it. I'm not concerned by that, okay? Some facilities have protocols, so if baby's born to a gestational diabetic, baby's over a certain weight, they have protocols they follow. Like they have to check the sugar so many times in the first 24 hours of life and make sure that they're above, 40 or 45. That's not true in every facility. And again, we would be more concerned about a baby who's not eating, but also is not responding as expected. So if they're more lethargic, they're a poor eater, they're not peeing, they're not pooping, their vital signs are outside of normal range, then that would also make me concerned about glucose. Okay, it's not just whether or not mom had diabetes. Now, in terms of the liver has to convert unconjugated to conjugated bilirubin, okay? So when I think of unconjugated, that's bad, okay? Conjugated, I can get rid of. And how babies get rid of bilirubin is through urine and stool primarily. So that's one of the reasons why we want them to pee and poop. So the question is, what if my mom had meconium prior to delivery? Does that mean they're at less risk of having jaundice? Not necessarily, okay? It has to do more with kind of this, and I don't think I have a slide on it. Yeah, I don't have a slide on it. It has to do with enterohepatic recirculation of bilirubin. So if things stay in the gut, you actually reabsorb bilirubin and you don't excrete it. Because what will happen is you conjugate it, and if it doesn't get excreted, it'll go back to unconjugated. When you look at bilirubin reports on babies, a lot of times they'll say total bilirubin, and the total bilirubin is unconjugated and conjugated together. Okay? But we're more concerned again about the unconjugated. That's bad. So we're trying to get more. We're trying to get it more into conjugated so that the baby can get rid of it. So physiologic jaundice, when I hear the term physiologic, normal, expected. Doesn't need a lot of intervention. So with physiologic jaundice, the reason this happens is we have this rapid destruction of red blood cells by the baby. We have, this alteration in terms of how you conjugate bilirubin, but also how you reabsorb bilirubin through the GI tract. So that's, again, one of the reasons why we like breastfeeding, because colostrum has a laxative effect, and you're going to get rid of that bilirubin and that meconium that much faster. So 60% of full-term babies, 80% of preterm babies. So if your mom delivers a baby at 35 weeks, and she asks you, is the baby going to need to be under bilirubin lights? More than likely, there's a very good likelihood that yes, that may happen, okay? The other thing is, they don't always use Billy lights. A lot of times they use a Billy blanket. And a Billy blanket's nice because you can hold the baby. You don't have to, hands off with the baby. And it puts the ultraviolet light very close to the baby so they can, again, it converts through a very interesting chemical process, unconjugated into conjugated bilirubin. That's the purpose of the ultraviolet light. Now, with jaundice, we may see visible jaundice in the baby when the bili is greater than 6 to 7 or so. Some of you may have done a little scanner on the baby's forehead to check for bilirubin. It's non-invasive. Sometimes you just go, you run it across. It's a screening test. I think TCI is what I know it as. Transcutaneous, I don't know what the I is for. There we go, that works for me. But basically, you look at the number and you apply it to off gestational age and day of life. Is it concerning, not concerning? It gives us a picture about whether or not we need to do a heel stick to look for a serum bilirubin level. Okay, so it's non-invasive. But for what I do is I always want to look at my baby under bright light. Jaundice tends to progress from head to toe. So if they have facial jaundice, that's milder than if they have jaundice down to the chest and nipple line. If you have jaundice down to the chest, nipple line, that's a baby that often needs some type of intervention. You have to remember, in babies that have darker colored skin, it's not easy to see that kind of yellowish cast in the skin. So I tend to look in the conjunctiva. You might see it in the sclera a little bit better. But a lot of parents and caregivers, they're like, oh, look at the baby, so cute, it looks like a little pumpkin. Like, ew, pumpkin is cute. It has this nice kind of rosy, orangey complexion, but that's actually not good. So with jaundice, it is really important that this occurs after the first 24 hours of life. Tends to peak around day 3 or so. And the best thing you can do is prevent it. So feed the baby, feed the baby, feed the baby, and that'll make the baby pee and poop more to get rid of that bilirubin through the meconium. The other thing is making sure your baby's temperature is stable. And that's another reason why sometimes moms who breastfeed, if they're struggling with breastfeeding, that sometimes then the baby has jaundice after that. That is different completely than breast milk jaundice, okay? We're not even really gonna talk about breast milk jaundice. I hate even bringing it up because it just confuses people. But if somebody's breastfeeding and the baby has jaundice, we actually want her to breastfeed more, not less. Okay. All right. So, here we go. The 3 types of jaundices. By far, I would pay way more attention to physiologic jaundice. That is the most common. Breastfeeding jaundice, again, very transient. Again, sometimes the baby might need an intervention, but it tends to resolve around day 3 because guess what? That's when the milk comes in when you breastfeed. So the quantity goes up significantly, so we see more GI motility, and again, that reduces then the reabsorption of bilirubin from the gut. This last part, this breast milk jaundice, ugh, I even hate it that it's on there. It is rare. It tends to happen much later, so it's something we would not see in OB. You would see it in pediatric land. The bilirubin goes significant, I mean, really high after the first week of life. And that's a baby who is having problems breaking down the milk and the product of breastfeeding. It's only in that situation that mom may need to temporarily stop breastfeeding. So again, you might just draw kind of an X through that. I would focus more on physiologic jaundice. And again, with breastfeeding, sometimes those babies can see a little bit of jaundice. The other thing you gotta remember is, sometimes it's not the breastfeeding. So you've got a mom who's in tears. I'm trying to do everything for my baby. It's not breastfeeding jaundice she has. It's that the baby has ABO incompatibility. So it has to do with mom's type O, baby's type A,